name is Gustavo Saposnik. I'm one of I'm the editor-in-chief of the World Stroke Academy. And we have the opportunity and the privilege today to have two speakers, or two of the first authors of the ACT trial. Dr. Bijoy Menon is a professor of neurosciences, radiology, and community health sciences at the University of Calgary and at the Hutchins Brain Institute in Calgary, Canada. And Brian Buck is an associate professor of medicine at the University of Alberta, also in Canada. Both are not only outstanding clinicians and scientists and stroke neurologists, but also very esteemed colleagues. So welcome and thank you for the opportunity to having you, Bijoy and Brian.
Thank you, Gus.
Thanks for having us.
Excellent. So let's go to talk about the ACT trial and what you have done. So you just published the first phase 3 pragmatic trial comparing tenecteplase versus acteplase. So how would you summarize the main findings, especially for clinicians? We are not into the detail. Remember, some people may not fully understand what a non-inferiority study may look like, or what that would be. So just some brief summary.
Thank you, Gus. I'll take this question.
Sure.
The ACT trial was a large phase 3 trial trying to show that tenecteplase is in fact comparable to alteplase in patients with acute ischemic stroke who present early after stroke onset, so within 4.5 hours. We wanted to generate that evidence to show comparability of these two drugs, with the idea that if they are comparable, then because of the obvious advantages of tenecteplase, including its ease of administration and possibly cost efficiencies, that people would just consider switching from alteplase to tenecteplase. That was the trial. It was a large trial. Its inclusion criteria or eligibility criteria, as Gus, you mentioned, was pragmatic, which means it directly applies to patients in our practice. And at the end of the trial, we actually showed that for the primary outcome, tenecteplase was in fact, similar, slightly around 2.1% better than alteplase. And when we compare safety, it was all the same. And so we achieved the objective, which was to show that these drugs are comparable, which means that in our practice now, we can actually switch over to tenecteplase as the thrombolytic drug of choice.
Thank you, Bijoy. That's very clear. So people may wonder, okay, but tenecteplase may be very similar to alteplase, but what are the advantages essentially of tenecteplase? Is another kid on the block, or is something really, a game changer?
Brian?
Yeah, so I mean, there's a number of pharmacologic advantages. So it's got a longer half-life, it's more fibrin specific, and there's also a very important logistical advantage. It's much easier to give. You don't need an infusion pump. It's given as a single injection. And I would say that an additional advantage, which people often don't talk about, is how it's viewed in the emergency community or emergency medicine community. And that was one of the things that I found really surprising and pleasantly surprising when we were running this trial at our site. For decades, the ER community has always viewed alteplase with a bit of suspicion. They're not as comfortable with alteplase. There's been concerns around the hemorrhage rate with alteplase. And we did not encounter that resistance when we were using tenecteplase in the trial. In fact, the emergency medicine community and emergency staff during the trial were very actively involved in the trial. They embraced having this study running at our site. And from the colleagues that I've talked to since the study is being participated, they're actually quite excited about the opportunity to replace alteplase with tenecteplase, especially when they learn that we're using half the dose that they've been used to using for years for acute MI. I'm not sure if you have any additional comments.
Yeah,
no, that's clear. Yeah.
Maybe, Gus, with your permission, I could sort of add what I think is another important aspect, and it comes from, my own sort of background, having, originally coming from India, that, whenever we thrombolize, our goal is to achieve optimal outcomes at reduced cost. And this is really important because, why would we want to spend more on something if we can spend less on something but achieve similar and if not better outcomes? And this is clearly something that tenecteplase does, which is why cardiologists have been using tenecteplase for the last 15 years. After ASCEND-2, which compared tenecteplase to alteplase, they switched over. In ASCEND-2, the drugs were similar. So in middle and low income countries especially, cost is a big factor. And here you have a drug that potentially could actually be less expensive, not just the drug cost itself, but also, as Brian mentioned, the other costs, which includes, setting up infusion pump, running around with that, the issues that happen with monitoring, the time that's spent, the faster transport that happens, the easier transport. All of these things are significant advantages in an emergency like acute stroke. And therefore, I think, it's just common sense that if we find that two drugs are similar, and just to be mindful of the fact that if you just look at point estimates, tenecteplase is, slightly better. And if it is less expensive, easy to do, saves time, saves cost, then why not switch?
Excellent. Thank you very much both for clarifying. Now, a little bit of a provocative question, okay? So this is an open question, and it's, imagine I'm a clinician sitting somewhere else, not in an academic center. I don't understand, very much, what the details of a trial. But, Bijoy, you also mentioned that the difference, the effect is 2%. So how much should I work for a 2% benefit? So is that meaningful? So what does it mean? And this is going back to the other trials, stroke trials, essentially is 20 years ago, we have magnitude of the effect of absolute difference in the range of 15 to 20%, 25. Now, most of the recent trials are showing very small magnitude of the effect. So what does it mean for clinicians?
Yeah. No, that's a great question, Gus. And Brian, maybe I'll start and then you can chip in too. So it is a reflection of where the acute stroke is in terms of treatment that our effect sizes are dropping. And so many years ago, and I still remember when I was in med school, there was not much we could do except, it was the time when thrombolysis was first starting. And we didn't have much treatments. And so when you do not have any treatment in your field, and then you have your first treatment, potentially has larger effect size. And this is what happened with endovascular thrombectomy. It is the sign of a maturing field that we now have trials that are actually looking for small marginal differences and comparability. Remember, comparability is really important because we want to move towards more efficient paradigms. And so it's just, if I have, let's say, $20,000 and I have an old car and I have a new car for the same price with better technology, then would I switch or would I not? And so if these are similar, and one is clearly, better because of other reasons, then it makes sense for me to switch, although both cars will take me the same distance. And so this is the way I look at this. Now, in terms of effect size difference, again, a maturing field, so we see this in cardiology, oncology, and now increasingly in stroke, is where, you are looking for comparability trials and marginal effect trials, because at the population level, they start making a lot of difference. And so a 2% difference or a 3% difference, when you translate it into hundreds of thousands of people, is actually a big deal. And so, that is why this has impact. Not to mention the fact that, saving costs clearly means, and especially in, like lots of countries, that more people will likely get treated. and which means that, there would be more benefit at the population level.
Thanks, Bijoy. Do you want to add anything, Brian, or we move to the next one?
Yeah, we can move to the next one. That was very eloquently answered.
So the next one is related essentially with, it's like a follow-up. So now, so we have some meta-analysis showing benefits of tenecteplase over alteplase for reperfusion, for early neurological improvement, and for the primary outcome, functional neurological outcome. So what do you see that the stroke field is moving in the next 5 or 10 years? So the question is more about your vision and related with the previous question. So you were talking, Bijoy, about new paradigms. You make the comparison between a new car and old car, that at the end of the day, you will reach the same outcome. But the question is that the treatment effects are being smaller. So the question is the faucet getting close? Do we have to think about new paradigms of acute stroke care? We are talking about the acute stroke, not overall. So where do you see that the field of acute stroke care is moving?
Brian, you want to start?
Sure. So in terms of thrombolysis for acute stroke, we've essentially been using the same selection criterion paradigm for decades now. And I think now that we have a new thrombolytic medication or essentially a new car, we can now start to test what the limits of this vehicle are. And I would say that in the future, we're going to start pushing the boundaries. So previously, for example, subgroups of patients that were not treated with thrombolysis. So for example, patients that recently had received a dose of an anticoagulant, we've typically not treated them with medications like alteplase. Having a new, potentially, at least on paper, safer thrombolytic medication allows us to start designing trials to test whether thrombolysis is now safe in patients, for example, that were treated recently with anticoagulation, patients that may be presenting beyond 4.5 hours. So I would say that the future is testing how far we can go with this new thrombolytic medication that we now have in our toolbox. Bijoy, do
Yeah, no, thanks, Brian. I agree. In addition, I just think, as Brian pointed out, that this is just the beginning, that there is, but to your point, I also wanted to mention that increasingly, it is a sign of a mature field that we would actually start thinking of better outcomes. And I know, Gus, that this is one of your topics of interest too, in the sense that, at first we may just be focused on mortality. Then we focus on functional outcomes, as we do right now with the Rankin. But then we would sort of, look for, say, cognitive outcomes. We'd look for economic costs. We would look for microcosting data, economic analysis. We would look for, other sort of, patient-reported outcomes. And as we move towards, as our field matures, we look at this thing holistically as to how it makes a difference to patients' lives and to society. And so these outcomes would sort of, start being different. And so, for example, with tenecteplase, you would see that with the Rankin, you have a 2% difference. But with cost, you may have significantly more difference. And that has societal implications. We're looking at cognitive outcomes. We're looking at, say, home time. And these might actually, have more of a difference. And so that's how, the field would mature into the future in terms of outcome ascertainment. But in terms of therapy itself, as Brian pointed out, I think tenecteplase now offers us this opportunity to test, to expand indications, a big paradigm leap, possibly even next year, with potentially the release of the timeless trial. Results might be that we would actually start offering thrombolysis in the extended time window, which is a big deal because, why would it be that just because we sleep and we are humans wired to sleep, that somebody who has a stroke during sleep is not treated now? And so, those type of things would become more important. In middle and low income countries, transport is sometimes, takes time. And so just because you were delayed, you may not be offered thrombolysis now, but this might actually change in the future. So that becomes, a bigger deal. I also think that, they could actually be lytic enhancers, neuroprotection agents, and these would all sort of come together with the lytics to actually provide more effects. Our work is not done. If you actually look at the Rankin 01 rates in ACT, that's around 35-36%. The Rankin 02 rates are around 50% to 55% or so, which means that still around 40 to 50% of people, when they have a stroke, do become disabled. And so can we then, and Brian's actually leading some of that effort in Canada, providing thrombolysis in ambulances. And so sort of bringing patients, getting the thrombolysis closer to them. New technology will help us achieve that too, portable scanners, early detection. And so to us, to anybody who's actually joining the stroke field now, this is a field of immense opportunity and progress. And so I feel, these are super exciting times in terms of what's going to happen in the next 5 to 10 years.
Thank you both, and thank you very much appreciated. And now let me show you one slide. This came up, I just created that. So can you see that? So yeah. Some challenging situations. So I propose, a 3 minutes pinpoint question, whether you play chicken or tiger. If you play chicken, that means that for every scenario, you have to think about it. Or you are not sure, but you are not right away pursuing, let's say, treatment with tenecteplase, okay? If you say that you are the tiger, you go ahead, no questions asked, okay? So assuming no contraindications, okay? No formal contraindications. So the question is, imagine that you are seeing somebody in the range of 70 years old with no contraindications, and I will keep no information about large or no large vessel occlusion. In your trial, you didn't show any major differences. So the question is, somebody with a low NIH, let's say 3, who is, let's say, a farmer. So would you play chicken or would you play tiger?
So maybe I'll go first. Low NIH, I'm more the tiger. I feel it's relatively safe, and there's a potential for patient benefit even with low NIH.
Yeah, I'm a chicken. I still have uncertainty. I think the Tempo 2 trial is going on. The PRISMS trial, did result in some of us chickening out. Hopefully, the Tempo 2 trial results would actually inform us better. But I do sort of weigh risks and benefits in these patients, and consider that these patients are candidates for ongoing trials. So
certainly, these are very controversial, so that's why. Second, pre-existing disability, modifying ranking scale 3 or above, let's say from a nursing home.
I am a chicken there.
Chicken.
ACT was a pragmatic trial, and therefore we didn't actually restrict patients with pre-existing disabilities. And so just the evidence that you could actually use tenecteplase, as you would have done with alteplase, does exist in these patients. But the question is whether what is the extent to which they benefit. And I think, we need more data to actually understand this. That's my opinion. Brian?
Yeah, I don't have much to add other than I agree with you.
Okay. How about somebody who has a cognitive impairment, I would say dementia, with some degree of frailty? So, somebody in the context of being defined as frail. But again, you know, in terms of they are ambulatory, require some using a walker, for example, but a modified ranking scale of 3.
I think this
Right.
overlaps a bit with the previous scenario, and I'd probably be the same. I'd be a little bit chicken about treating these people in the absence of more data, and we're in the process of looking at this subgroup. These types of patients were enrolled in ACT.
That's correct. Yeah, we did actually enroll some of these patients in ACT, so we'll have that data. But tenecteplase is benefit over alteplase. But I do think, you know, with this recent news about this drug called lecanemab, which could potentially, you know, like be potentially be game-changing with Alzheimer's dementia, that we got to now think of whether, you know, these diseases are potentially, like dementia is potentially reversible. And if that's the case, that changes things too. And then the idea that dementia is multifactorial. And so, you know, like if it is amyloid angiopathy, I'm sort of worried about risk. And so I think, you know, patient characterization with frailty and dementia is really important. But I agree, I sort of chicken out sometimes. I think, you know, more data would be helpful.
Thank you both. Last question. You have somebody who had the CT perfusion, even when it may not be a standard of care in everywhere, but imagine somebody coming within the time window with a large core, the CT perfusion, let's say 4 hours after symptoms onset, show a large core. A large core is, let's say, over 70 milliliters.
So I am a tiger when I'm in a primary stroke center, but I might chicken out if I'm in a comprehensive stroke center. And so that's the way I look at it, which means
so you
that
change your face. So you play
I do.
chicken in a primary, but you play tiger in your center.
No, I meant the other way around. Like, if I did not have the endovascular thrombectomy option,
okay, yeah.
I think, you know, like there is no good evidence to say that we do not have any evidence to show what I call, you know, heterogeneity of treatment effect by core size with thrombolysis. We do have some suggestion that maybe the risk is a little bit higher, but there is not much evidence to actually withhold treatment in people with larger cores. I'm not saying, you know, like a completely large evolved infarct. You mentioned that these are patients who present within time window or early. But if I am in a comprehensive stroke center where I have this benefit of using endovascular thrombectomy, then I wonder whether, you know, thrombolysis may be needed. I'm also questioning the need for endovascular thrombectomy, but that's another debate in itself, where there are a couple of trials like the Japanese LIMIT trial, and I presume the SELECT-2 trial results will come out that will actually inform us better for what to do with large cores. But in a comprehensive primary stroke center, we just sort of, you know, like not worry too much and offer thrombolysis.
We need consent, Bijoy, just to follow up on your answer. So suppose that you have a large core. Do we need consent?
That's a good question. This is actually jurisdictional dependent. At least the Canadian best practices are that we do what we think is in the best interest of a patient informed by these guidelines. And here we do not, if, you know, patients and families, if families are not around, we would just go ahead with treatment.
Ryan, any other comment? Are you chicken in this one too, or you share Bijoy's perspective?
Yeah, so we're one of the, you know, we're a site that actually does CT perfusion routinely, and it does become challenging because we're doing it in a lot of our patients under 4.5 hours, and I just don't think we have enough data to really tell us, you know, how these thresholds for defining core change with time from stroke onset. And I think it's a bit dangerous making thrombolytic decisions incorporating perfusion into the decision making. We actually encourage our fellows and residents to focus on the non-contrast CT and CT angiogram and making their thrombolysis decision, and then adding in the information from perfusion and deciding things like thrombectomy and how to further manage the patients. So I guess to answer your question, I'd prefer not to know what the perfusion looks like and focus on what the non-contrast CT looks like when I make my thrombolysis decision.
Thank you very much. I think that this is very helpful. And on behalf of the World Stroke Academy and the World Stroke Organization, we would like to thank you very much for sharing your expertise and also for the amazing work that you are doing. Thank you both very much.
Yeah, and thanks, Gus, and thanks for the amazing work you are doing, because the work you do translates all this knowledge and truly has impact. So thank you.
Thank you.
Thanks.